We come to the part 2 of neurology notes. Cluster headache, it usually occurs several weeks once a year, like 4 to 12 weeks in 1 year. Men, 3:1, men is to female. The propensity is more in men than female. Smoking and alcohol are trigger factors. Nocturnal sleep will be there. Clinical feature occurs once or twice a day. For around 15 minutes to 2 hours. There's this intense, sharp, stabbing pain around one eye. Redness, lacrimation, and lid swelling is there. Nasal stuffiness, miosis, and ptosis in minority patients can be seen. Management: acute around 100% oxygen, subcutaneous triptan you need. Prophylaxis, verapamil. GBS, demyelination of the PNS, peripheral nervous system. So the causative factor is Campylobacter jejuni. Anti-GM1 antibody ascending paralysis, Miller-Fisher syndrome, ophthalmoplegia, areflexia, and ataxia. Eye muscles first effective. There is descending paralysis in Miller-Fisher, and it has got anti-GQ1B-AB antibody. Motor neuron disease, usually the causes are known. It occurs in more than 40 years of age. ALS, PM, BP, PLS, all this full form I'll tell you later. Clinical features will have fasciculations, absence of sensory signs and symptoms. So there is no sensory loss in motor neuron disease. Now, you will have LMN and UMN or only UMN palsies here. Wasting of small muscles of hand, tibialis anterior is common. Okay? Then legs and hand. Doesn't affect extraocular muscles. So there are no cerebellar signs in this. Okay? So if you see cerebellar signs, you can rule out this option. If you see any extraocular muscle involved in the question, you can rule out this option. Abdominal reflexes are preserved. Sphincter dysfunction can occur, but usually it's a late feature. Electromyogram pe there will be decrease in the action potential and increase in the amplitude. Now MRI you need to do only to exclude differential diagnosis of MND, that is cervical cord compression and myelopathy. Usually the MRI is normal in these conditions. How will you treat motor neuron disease? Now in general you can give riluzole, which prevents stimulation of glutamate receptors. In ALS, amyloid lateral sclerosis, prolongs life by around 3 months. Respiratory care, NIV BiPAP at night. Prognosis: 50% of the patients with motor neuron disease die within 3 years. Okay? Now there is something called as acid maltase deficiency, which is a DD of this. In this there is insidious onset, proximal myopathy, and there is early respiratory muscle weakness. Okay. Now motor neuron disease types, you have amyotrophic lateral sclerosis, which is there in 50% of all the MNDs. Lower motor neurons in the arms and UMN's palsy in the legs will be there. There is mutation of chromosome 21, which codes for superoxide dismutase. In primary lateral sclerosis, there will be only upper motor neuron signs, palsy signs. Progressive muscle atrophy, there will be lower motor neuron, which has got best prognosis. Now in this, the distal muscles will be affected before the proximal muscle. Then you have progressive bulbar palsy, PBP. This is there will be palsy of the tongue, the muscles of chewing or swallowing, facial muscles due to loss of function of brainstem and motor nuclei. Now this has got again the worst prognosis out of us. So इसमें क्या होगा? Tongue palsy, muscles of chewing and swallowing, facial muscle due to loss of function of brainstem, motor nuclei, worst prognosis will be there. ठीक है? Stroke assessment, we check the FAST, that is face, arm, speech, time. The positive predictive value of this method is around 78% in general public. So there is something called as a Rosier score, which first you have to exclude hypoglycemia. Then you give 1 point to each of these symptoms, -1 if it is got loss of conscious, and -1 for seizures. If there is new or acute or symmetrical facial weakness, 1 point, arm weakness, 1 point, leg weakness is 1, speech disturbance and visual field defect is holds 1 point each. Now involvement non-contrast CT head is to be done immediately. Acute ischemic low density in gray and white matter hyperdense artery. Acute hemorrhagic stroke, areas of hyperdense material in blood, low density edema can be there. ठीक है. So this is how you will differentiate between them. Ischemia में low density, hemorrhage में hyperdense material, that is blood. ठीक है. In the white matter, hyperdense artery and low density edema. So then how will you manage? You will give isotonic saline without dextrose. Now what happens? Hyperglycemia increases the mortality independent from age or severity. There will be tissue acidosis from anaerobic metabolism. The blood sugar level is around 14 to 11 millimoles per liter. In diabetes, there is intensive management for diabetes post acute stroke. Then blood pressure, you only decrease it in case of emergency, hypertensive emergency. You can decrease around 15% in around 24 hours. You can give labetalol, nicardipine and clonidipine. Candidates for thrombolytic therapy for acute stroke. Blood pressure should be decreased by less than 185/110 and should be maintained so for 24 hours post therapy. How will you manage stroke? You will give 300 milligram of aspirin ASAP. The target blood pressure is around 220. Atrial fibrillation, anticoagulation, you have to give not until hemorrhage is excluded, not until 14 days from the ischemic stroke. Now if cholesterol is more than 3.5 millimoles per liter, then you need to give a statin. Now most physicians delay the treatment after at least 48 hours due to risk of hemorrhagic transformation. Thrombolysis for acute ischemic stroke, you give alteplase 4.5 hours and you need to exclude hemorrhage. Contraindication, pregnancy more than 200/102/20. Relative contraindication, INR is more than 1.7. Hemorrhagic diathesis, active diabetic hemorrhagic retinopathy, major surgery or trauma preceding 2 weeks. Thrombectomy 6 hours symptom onset. ठीक है. So you can perform thrombectomy at least 6 hours from the symptom onset and thrombolysis 4.5 hours. ठीक है. The two contraindications of thrombolysis are pregnancy and blood pressure. Thrombectomy is to be done when the modified Rankin scale score is less than 3 and NIHSS score is more than 5. 6 hours if there is blockage in the proximal anterior circulation, anterior cerebral artery and middle cerebral artery. 6 to 24 hours if there is blockage of proximal circulation, if there is potential to salvage brain tissue as shown by imaging such as CT perfusion and diffusion weighted MRI sequence. Less than 4.5 hours, 24 hours, proximal posterior circulation, basilar or posterior cerebral. ठीक है. Secondary prevention, you give clopidogrel. If this is contraindicated in stroke, then you give aspirin and MR, modified release dipyridamole. This treatment is limited to 2 years. And then you can give modified release dipyridamole if aspirin and clopidogrel are contraindicated. ठीक है. Now all patients who are suspected of non-disabling stroke or transient ischemic attack who are considered for carotid endarterectomy should have been carotid imaging within first week after having stroke. So carotid end arterectomy, stroke or TIA not severely disabled. Carotid stenosis more than 70%, yeah, more than 50%. This is according to the European guidelines and this is according to the American. How will you management of carotid stenosis outside of acute stroke? Does not have the same urgency, so should be managed by specialist in OPD. Okay, so this is important while answering these questions, because these are the difficult ones. Okay, so you have to decide whether the patient has come in emergency or in acute or in OPD setting. Okay, and then you check the frailty of the patient. How old is he? Can he take this surgery or not? Okay. Now we come to